person-centered quality indicators with diverse communities, a qualitative patient engagement study. And so this is just an overview of the presentation. I'll go over the study background, the study design and methods, in particular discuss, some of the, the theoretical lens that we're coming from our partnerships, as well as the participatory approaches that we used. I'll talk a little bit about the results from our study, especially, the action part of it. So this is a participatory action research project. And then the discussion, so some of the strengths and limitations of our research, some of the lessons that we learned, as well as some of the next steps. And so just some background, I know a lot of people will be familiar with this, but just to get us all on the same page, when we're talking about person-centered care, we're talking about a model of holistic care that engages patients and caregivers in healthcare and recognizes the importance of providing personalized care that affirms the dignity of the patient. And so person-centered care is a key component to providing high quality healthcare, but it doesn't tend to be evaluated or measured from the patient and caregiver perspective. And so, with this major gap, Dr. Santana has been leading a research project on developing and implementing person-centered quality indicators, which are informed by patients and their caregivers to help guide improvements to make sure that healthcare is person-centered. And so the key question for us with this research project is, what matters to patients? What matters in their care? What matters in terms of how we evaluate their care? And just a little bit more background on the PCQI study, of which this study I'm going to be talking about is a sub-study. And so person-centered quality indicators, these are quantitative measures, like they're metrics that help to give a sense of how the healthcare system is doing. And for us, we wanted to see, is the healthcare system person-centered? So indicators might be things like, does this clinic or does this hospital have a policy on person-centered care? How is the communication between patients and their healthcare providers? Do patients feel like their care is affordable? So these are kind of the indicators that we've been looking at, and that what we were able to develop through this multi-year research project, which, as I mentioned, started in 2015 and is still ongoing because it's such a massive project. And so we see PCQIs, person-centered quality indicators, as a driver for change, because if you're able to measure and evaluate what the gaps are in person-centered care, you'll then be able to improve it. So our healthcare providers, quality improvement staff will be able to say, okay, these are some of the gaps. This is what we're going to do to improve it. So communication is a gap. Maybe we develop a checklist, for example, to make sure that we're doing everything that will make sure that we're giving the patients enough information and communicating with them in a way that is respectful and compassionate. And so because this is all about person-centered care, of course, patient community engagement has been just an integral part of this research. And one of the important aspects of this research is really looking at the question, whose voices are and are not incorporated in evaluating person-centered care. And so as you can see from this big figure, this research that I'll be talking about is part of phase 1, where we were identifying the PCQIs. So we wanted to know what matters to patients, how do we evaluate what matters to them. Okay, and so as I mentioned, we want to talk about some of the challenges with engaging people. And often there are people who are underrepresented in research and in healthcare policy. And so, effective engagement of underrepresented and diverse communities in health research is a challenge because there are a number of barriers related to participation. So, certainly like race and language barriers, some of our implicit biases that might impact participation, but also geographic regions. So maybe you're in a rural area and not engaged. Age might be a barrier, abilities. So some of these different, different factors that we need to consider when we're engaging people. And so evaluating person-centered care needs to reflect what matters to everybody, not just those who can or are able to participate. And so our study aim was to meaningfully engage diverse patients and communities in the development of the PCQIs, as well as initiatives that might improve person-centered care. So for this research, we wanted to identify themes of person-centered care from the perspectives of diverse patients and caregivers, with a focus on immigrant and newcomer communities who tend to be underrepresented in research. And we also wanted to use innovative participatory approaches to engage ethnocultural and immigrant communities in qualitative patient-engaged research. And so the approach that we used was called the qualitative descriptive approach, which was described by Santana in 2010. And so we use this approach as we wanted to describe the patient and caregiver lived experience with healthcare. We wanted to identify similarities and differences across groups, and that focus group discussions were chosen so that we could have a broad range of different perspectives. And as I mentioned at the start, we did use the transformational paradigm, which was described by Mertens in 2007. And so we chose this as our paradigm with a recognition that, knowledge is not neutral, and that there are differences in terms of power relationships that exist within society that impact people's ability to be able to participate. And so this guided us to center the experiences of traditionally marginalized communities, to analyze the power differentials that might lead to marginalization, and also employ research methods that are drawn from participatory action research practices. And so one of our key research partners was Action Dignity. And in 2016, 2017, when we did this research, they were formerly known as the Ethnocultural Council of Calgary. So Action Dignity is a community-based organization that facilitates the collective voice of Calgary's ethnocultural communities towards full civic participation and integration through collaborative action. They employ like a cultural or community broker model, where they have people that are based in the community who their role is to really act as that liaison between communities as well as institutions and organizations in order to facilitate, systems and policy change. And the organization also provides specialized training to community brokers, also just known as brokers, to effectively engage communities. And our other key research partner was Alberta Health Services, in particular the Patient and Family Advisory Group. And so while our focus of the study was trying to engage immigrant and newcomer communities, we also wanted to ensure that we were considering other aspects of diversity. So as I mentioned, people from different areas of Alberta, people from Indigenous communities, different socioeconomic backgrounds, different abilities. And so this is where Alberta Health Services was able to help us in engaging some different people. And so part of this model of working with the community brokers with Action Dignity was to be able to, there's this major strength in having this person who is trusted, well connected to the community, who shares a language, but really understands some of the issues faced by their communities. So that strength, we wanted to utilize that in research so that we could connect these communities with, the university, but also with Alberta Health Services and with the Provincial Health Services. And so these communities we had chosen with Action Dignity. So these communities were those that come from extensive, longstanding communities like the Chinese, South Asian, Filipino communities, but also those that are growing and emerging, like the Latino Hispanic community, the East African community, and the Syrian community. And so the brokers received training by the research team and Action Dignity. So Action Dignity actually has a well-established history of doing community-based research. And so together we provided training over 4 evening sessions, which doesn't sound like a lot to do research, but we want to ensure that people are able to make time to do it. So we covered topics like how to recruit participants, to conduct and transcribe the focus group discussions, support analysis and interpretation, and disseminate the findings. And because, it's really hard to get people together for a couple hours in an evening, we also provided ongoing mentorship over the course of 9 months. And so as we're doing this research project between our research team at the University of Calgary and Action Dignity, we were meeting with brokers individually and as needed to be able to answer questions, but to even just, support as they were leading some of this research. And so the brokers also completed a confidentiality agreement, and they received a training certificate from the O'Brien Institute for Public Health, and an honorarium of $1,500 just as a thank you, with a recognition that, if we're doing this today, we'd be able to maybe provide more compensation, just with a greater awareness of the importance of the contribution of some of the community and patient researchers. And so with our participant recruitment, we recruited 6 to 10 members from the community to participate in the focus groups, striving for maximum variation, meaning that we wanted to get, a diverse group of people. We used a mixed sampling approach. And so, it wasn't just flyers or word of mouth. We tried to use different approaches that would work well for specific communities. And this was advised by the brokers. So we used snowball sampling where, people knew somebody else who might want to participate. They would refer us to them. We also use convenience sampling, which means that, if there was an event going on or organizations that were meeting, that we would take that opportunity to recruit participants. We also use social media like WhatsApp groups that were available where lots of people from a certain community might be part of, as well as ethnic media. Our inclusion criteria, so participants had to be from the target communities, fluent in the language that the focus groups were conducted, had to be at least 18 years of age. They had to have access to the healthcare services, not employed by Alberta Health Services, so they don't have a specific bias kind of for or against the services that they've been receiving. And for our immigrant and newcomer communities, that they've lived in Canada for about 2 to 10 years, so considering that they're relatively recent. And for our focus group discussions, which we held with the Patient Family Advisory Group, we had 30 members who participated, so they represented more long-term residents of Canada, and as I mentioned, other aspects of diversity. They all had experience with the healthcare system or have been caregivers or family members, and again, they had to be at least 18 years of age. So in terms of our data collection, we conducted the focus groups in community spaces. So these were even people's homes. They were nonprofit spaces. They're just spaces that people might feel more comfortable. And they're also conducted in the participants' native language, except for the South Asian and East African focus groups, where there's just a lot of different languages. And so those were conducted in English. The AHS focus group was conducted during a regularly scheduled meeting to make sure we weren't taking too much of people's time outside of what they were already doing. And they ran for about 75 to 90 minutes, including time for socializing, because that's a good way for people to feel comfortable and to start that relationship building, which we continue to do today, actually. So just kind of looking at some of the strategies that we use to address barriers for people to participate. And so trust being a major barrier where people would have challenges with recruitment and participation. In terms of our facilitators, so the use of the community brokers, having relationships and networks, including ethnic media, and the use of a participatory action approach. So this idea of like social justice aims where you can go to your participants and say, we are going to do something. If you have concerns, This research is intended to make improvements to the healthcare system. Cultural linguistic barriers. So again, brokers are familiar with the language and the culture. Barriers with capacity for people to do research. This is where training and coaching was really helpful. Accessibility and scheduling. So we used community settings, took advantage of already planned events, met people during evenings and weekends, and considering some lost income or expenses in terms of participating in research. So we provided gift cards, we gave out bus tickets, offered childcare, or we even had kids who attended the focus groups, and we also provided meals. And so all the focus groups were audio recorded, and then we did transcription and translation simultaneously by the brokers. So, they use their wonderful skills to be able to do something that's really challenging. And then we used a semi-inductive content analysis approach to be able to identify some of our themes and our sub-themes. And we also use these different measures to ensure trustworthiness. And so this involved frequent discussions between the research team members, and we also discussed the findings with brokers and with the people who participated in the focus groups. So for our results, we had a total of 8 focus groups, each having between 6 to 10 participants with a total of 66. One focus group was conducted with each of the 6 targeted communities, and 2 were conducted with members of the AHS Patient Family Advisory Group, who comprised about 30% of the study participants. And slightly more than half of the participants identified as women, and nearly half as Canadian citizens. Okay. And so I'm just going to kind of run through some of the key themes here. And so a major theme that came up was access to care. And as part of that, people talked about the availability and appropriateness of care, as well as the time to access care. How timely was it? So this related to the lack of availability of healthcare providers. Some people talked about the distance to services, and especially in being able to access the emergency department and to specialists. People talked a lot about the cost of care, which I know seems kind of confusing to people outside of Canada when you think about this idea of Canada having a universal healthcare system, but that people actually found healthcare costs to be a barrier, especially when you're thinking about things that are not covered. And so things like dental care, medications, different kinds of therapy like physio. And people were also concerned about the cost of services like the ambulance, if they didn't have coverage. Although people appreciate this idea that healthcare is free, and I say that in quotes because of course, people pay taxes, so it's not completely free, but that was appreciated, and certainly people found that to be a great way that you could access the healthcare services. And so here's one quote from somebody from the Latino Hispanic community who said she was crying in pain. This is talking about their daughter. So from there, I had to call an ambulance and I got worried because I didn't have any money. And I was told that ambulance services cost money and that it was expensive. And so, we talked with, a number of people from immigrant and newcomer communities. And so the theme around medical tourism and consultation came up, where people actually talked about because of issues with relation to being able to access care, that they actually consulted with doctors from home countries. And some people even thought that it was better to fly to that country rather than wait for services here in Canada. And another issue that people talked about, another major theme, was around communication. People talked about respectful and compassionate care, the issue around language barriers, and about having sufficient information. And so there was this focus on the importance of relationship building between healthcare providers and patients, and this recognition that, language barriers is an issue for a lot of people. And so here's a really great quote from somebody from the AHS patient family advisory group who said, patients are not valid in the eyes of many healthcare workers. They have no validity, and therefore they're ignored. So there's this almost talking down to you, and maybe you don't understand me. And I'm thinking, I'm not stupid. Do not dumb this down for me. All right. And so another two themes that had come up was the idea of patient caregiver engagement. So patients did see a lot of value in their healthcare providers engaging with them. They want to be part of making decisions about their care. And patients also talked about their preferences and their expectations of care. And so, especially coming from different countries, people are coming with different expectations. And so it's interesting to hear about some of those and how they might differ with others' experiences and their expectations. And there was also an issue around follow-up. And so, that idea that if you don't hear anything, everything's okay. So people had some issues with that, and people to talk about this idea of, feeling like you're on your own. And so, talking about some of the cultural differences, this person from the East African community had said, religiously, we don't have a problem, but culturally, no Somali female wants to face a man. And so people also talked about the theme of equality of care. They described, experiences around discrimination, due to their immigration status, language, gender identity, or sexual orientation. And so this actually discouraged people in accessing care. And then there was this idea of integrated models of care where patients talked about their value in centralized and coordinated care where services are located in the same area and that there's communication between their different healthcare providers. So here's one experience from the Latino Hispanic community. She was very rude, and it seemed like she didn't want to help me because I was a foreigner and because I didn't speak English. Okay, and the last two major themes that we found was around patient safety, where people describe situations of mismanaged care leading to poor health outcomes and experiences with family members that passed away, as well as professional ethics. So, patients and community members talked about the idea of informed consent and patient rights, so that participants wanted healthcare providers to ensure that they always do the right thing, trying to do what's best for their patients. And so focus group discussion participants had talked about the idea of informed consent and the importance of patient rights. And here's a quote from somebody from the South Asian community who said, "If you have cancer, by the time you get diagnosed, your cancer would have spread to the level where you can't be treatable." I had a friend, and he's from my background. By the time he was diagnosed, it took him almost 8 months here, like stomach pains. Start with that, the doctor gave him something, and after 3 weeks, he went again the same. By the time it was diagnosed, it was too late for treatment. And so I'm sure that we've heard situations like this, and they're not limited to the immigrant and newcomer community. And so, so we had a number of events to share these findings, and this was part of our, participatory action approach, where we wanted to share findings. We wanted to engage with the wider community, so that we could, see like what is most important to the community. We want to check our findings with them. We wanted to confirm what we had found, but we also wanted to get their ideas for how we might move forward. And so the first of one of these events was a report back to community event. And so the goal was to prioritize the themes for person-centered care. Because, we're developing these indicators, we wanted to make sure which ones were the most important. And we also wanted to see, which initiatives would we kind of work on first, right? Because you can't do everything all at once. And so we had more than 60 study participants and community organizations that participated. This included the Punjabi Health Center and HIV Community Link. And so the brokers, they were the ones who actually shared the findings from the research, and participants voted using Dotmocracy. So you may have heard of this before. And so it's a way where you can help to prioritize things where you have people And they have a certain number of votes using dots, and they just kind of go around and they identify their top priorities. And so the top priorities that were identified were timely access to care, culturally accessible language, patient caregiver engagement, respectful and compassionate care, patient rights, and the cost of care. And so patient caregiver engagement and respectful and compassionate care were addressed together. People thought that those would go, well together. And so we're able to kind of narrow it down to 5 priorities. And so the next event that we had was actually a provincial forum on person-centered care. And so the findings from the focus group discussions and the priorities that were identified from the community event were presented. So 111 people participated in the forum, and coming from a variety of different perspectives. We had people from the Ministry of Health, we had people from Alberta Health Services, from different community-based organizations, as well as patient organizations, study participants. And so it was a really great opportunity to bring these different perspectives together. And we also had, as part of this event, 38 participants from the different perspectives came together as part of a workshop to discuss each of the priority areas and to see how can we address some of these gaps that people have identified. And so, yeah, we identified the opportunities and initiatives, discussed considerations for implementing these initiatives, and also assess the feasibility. So, how easy will it be to make these improvements? Okay, and the strengths and limitations of our research. So, we were able to have meaningful engagement of diverse communities and stakeholders to inform the development of these indicators, as well as initiatives that would help to improve person-centered care. We used a transformational paradigm, so this research process that changes those involved. So, just being part of the research, it changed all of us, like working in partnership. We learned from each other. People gained all kinds of different skills in research, but in also how to engage meaningfully. One of the limitations was that we did not meaningfully engage Indigenous communities. So we recognized that, there's going to be different experiences and perspectives, and that some of the future research actually is that we would like to spend some time and to ensure that we're more meaningfully engaging Indigenous communities to understand their experiences and get some of their ideas in terms of how we can improve person-centered care. There is also a risk of selection bias with our research, as we did convenience sampling. So, just kind of going to an event, you might just have a bunch of people with some of the kind of the same, experiences, but also that they happen to be the easiest to get to participate. And so there might be some issues there, and also a limited perspective, mainly because we focused on 6 ethnocultural communities, but we were able to get wider perspective with some of our member checking with the greater community to help validate some of our findings. So in terms of our lessons learned, so the approaches that we used, we worked very closely with the brokers who really took a leadership role in this research. Food was really important, so sharing food together at all of our focus group discussions, but also our training sessions, and any opportunities where we gathered. Working in a community setting, ensuring that we appreciate people with gift cards, transportation, childcare, and having ongoing engagement at all levels. Partnership was very much a key to this research. We have built relationships and continue to build relationships. We developed terms of references and core principles together with Action Dignity in terms of having shared leadership. So while we had a coordinator at the University of Calgary, we also had a co-coordinator at Action Dignity. We had clear communication and accountability, as well as made sure that we had some common values and goals. So our future research, so the focus group discussion findings have informed the development of 26 person-centered quality indicators, which we were able to publish about a year and a half ago. And these were based on the perspective of patients and caregivers. And the prioritized themes have been incorporated into the I Know Health initiative. So some of the barriers and challenges that people had experienced, some of that learning was incorporated into the resources that have been developed in Alberta. And we have our continued partnerships with Action Dignity and Alberta Health Services for other person-centered care research. And so that's it for my presentation. Thank you so much for listening. And yeah, I look forward to the discussion and your questions.